Why don't we go ahead and get started? I know that people are still joining the call, but I just want to make sure that we have some time for questions and answers after my presentation. So for those of you who don't know me, my name is Margaret Flowers. I'm a pediatrician by training, and I live in Baltimore, Maryland, where I'm active with the Maryland chapter of PNHP, part of the Healthcare as a Human Right here in Maryland, and also serve as an advisor to the board for National PNHP. So I really appreciate. Oops, I have echo there.
Everyone should mute your phones.
Yeah, thank you.
Can we mute?
Yes, please mute your phones, and then during the Q&A you can unmute your phone to ask a question or make a comment. So I appreciate Matt for organizing this call and for PNHP inviting me to speak about incrementalism. The title of the talk is Incrementalism as an Obstacle to Improve Medicare for All and How We Resist It. So let me go to my next slide. And just to go through kind of the 3 goals that I hope to accomplish tonight on this talk. One, I hope that you have a greater understanding of the current talking points being used by progressives to promote an incremental approach to healthcare reform and how we respond to those talking points. Second, hopefully you'll have a greater understanding of the specific healthcare reform policies being proposed and their weaknesses. And then finally, we'll discuss some tactics to resist the incremental approach and strengthen our movement for national improved Medicare for all. And this slide should be available to everyone after the talk as well. Now I want to talk a little bit about where we are, and you'll see some of your faces in these slides. But we're at a very exciting point. You know, this year, the Republicans finally had the opportunity to make good on their threat for the last 7 years of repealing and replacing the Affordable Care Act, and they found that they were not able to do that. The Democrats really hoped that they would take what was happening and kind of move that energy to, we have to strengthen the ACA, the Affordable Care Act, or fix the Affordable Care Act. And what was really resonating as a message across the country in town halls, in marches, in the protests in Congress this summer was the message, no, don't repeal and replace the Affordable Care Act, but we want to go beyond that. We want single-payer, national improved Medicare for all. So we're seeing all kinds of groups that have, did you lose me again?
Oh.
Can you see? Okay. I apologize. All right, we're having a storm here, and my power is going on and off a little bit. But anyway, so we're at a very exciting time where a lot of momentum is building for national improved Medicare for all. So it was really interesting this summer, right after the efforts to repeal and replace the Affordable Care Act failed, and members of Congress went home for the August recess, we saw a number of articles come out in The Hill, in The Nation, in Salon, and other places, basically saying, hey, I'm a progressive, I think single payer is great, but there are other ways we can get there, or maybe we should talk about things a little bit more. So I put a couple of the headlines here of some of the articles that we've been seeing. And they all have kind of a common theme. It's, I support single payer, but improved Medicare for all is too much change at once. Single payer supporters don't have the details worked out. Other countries don't have pure single payer systems, so we should be, talking about other options. There's too much opposition to improve Medicare for all. We're hearing a lot about loss aversion, the idea that people don't want to give up what they already have, and people point to Obama's promises during the reform process in 2009, where he said, if you like your insurance, you can keep it. That people are saying we have to do what's politically feasible. And then some are just saying, I'm not sure what the solution is, but let's talk about it more before we really choose one. So it's interesting that we see variations of these talking points appearing throughout the articles that are out there. And also some interesting allegations that we're seeing in these pieces that Medicare for All supporters are somehow promising too much or not being upfront or misleading the public. And so we see, if you have your phone on, please mute it. We're seeing things like Medicare isn't actually a single payer plan because there are private insurance plans in the current Medicare Advantage plans. We're seeing Medicare currently covers less than what a high quality employer-based plan would provide. So people are going to be losing their benefits. They're saying doctors won't participate in the system because they won't be paid enough. And so people won't be able to choose their doctor. Or they say there's many different definitions of single payer. And so, of course, we know that if they read the legislation, HR 676, they would know that what we're talking about is creating a single publicly financed Medicare that doesn't include the Medicare Advantage plans, that the improved Medicare for All would be much more comprehensive than what Medicare currently offers and would actually not have deductibles or co-pays, that doctors would have the ability to have some input into reimbursement, and that doctors would be paid just fine and would have a lot less administrative burden, which would save them money as well as time. All right, let me go to the next slide. So before we move into kind of how we respond to the topics that we're seeing, I just want to bring up George Lakoff. And some of you may be familiar with George Lakoff. He's a linguist who talks about how we frame our messages. And he has a book that's called, what is it called? Don't think of an elephant. Because basically when if an opponent is putting out a message and they're saying something like, people are not going to be able to choose their doctor. Oh, I have someone saying that their slide is not changing. Can everybody see the slide right now that says our responses think like George Lakoff?
Yes.
Yes.
Okay, great. Okay. So, if somebody says something that's not correct, like people are going to lose their choice of doctor, the last thing that we want to do is reinforce what they're saying by using their phrase. And so, for us, it would be very kind of tempting to say, no, people are not going to lose their doctor. But when you start saying lose your doctor, that's what people hear. So we have to think consciously about how we respond and not answer with their language, but answer with language. So we would say National Improved Medicare for All provides the greatest choice of provider because people are no longer restricted by insurance networks or geographic boundaries. They can go where they need to go to see the doctor. So don't mention what they're saying is the key there. And then using positive framing. I put an example. We have all the resources we need to provide high quality health care right now. It's important to speak in terms of values because people are not swayed as much by facts as they are by kind of emotion. So remembering that when we're talking about these issues. And then Lakoff reminds us to repeat the truths about those values, to reinforce those values. And then finally, really important, is for us personally to have confidence and courage in what we're saying so that we can convey that when we're talking to other people and that comes across and makes them feel confident in what we're promoting as well. So some of our responses to the assertion that a single-payer healthcare system is too much change. What I often say to people is that the smallest incremental step that we can take towards a healthcare system that really puts health as the bottom line or our patients before profit is a National Improved Medicare for All, because it gives us an actual system and it gives us the cost saving to be able to provide high quality comprehensive care to everyone. That if we think back to 1965 or 66 when Medicare was implemented, it happened in less than a year. It was an entirely new system, and they didn't have computers. That we're already paying for universal comprehensive health care right now, so why shouldn't we be offering that like every other industrialized nation? That single-payer healthcare systems are well studied, proven to control costs and improve health, and that detailed proposals over the past decades have already been published in peer-reviewed journals talking about the transition and details of an improved Medicare for All plan, that we have models of single-payer systems in the United States that we can already use for comparison. And when people say that we need to include models like other countries have that include private systems, that privatization has really undermined healthcare systems, both in the United States, our public systems, and in other countries as well. When people say that we have to do what is politically feasible, we ought to remind them that one factor in the situation that we're in with the healthcare crisis, which we know the healthcare crisis is not going to go away until we actually do something to solve it at the policy level, that one of the most mutable factors that we have right now is kind of the political wind or the political culture, because we see that throughout history and even recently how political winds change with popular pressure. When they say that we should do what's politically feasible, we say we should do what will actually solve the healthcare crisis. And we can remind them that we already have a majority of the public who are supportive, health professionals are supportive, prominent business leaders and conservatives are coming out with support. And yeah, please do mute your phone until we get to the Q&A part. And that people are really inspired by bold solutions. They want to see a solution to the crisis, and if we start advocating for that in a confident way, then people are going to be inspired to fight for that as well. And that there will always be opposition to health reform, no matter what we do. The things that we heard being said during the process that created the Affordable Care Act, that there would be death panels, that it was socialism, that it was government-controlled health care, those were all of the same complaints that we were going to hear from the opposition if we were fighting for national improved Medicare for all. So our best strategy is to present something that's actually worth fighting for. All right, let's look a little bit at some of the incremental proposals that are out there. So Carol Shea Porter is a congresswoman who introduced the Medicare You Can Opt Into Act. It's called HR 2065. There is not currently a companion bill to that in the Senate, and she currently does not have any co-sponsors on that legislation. And basically, the Medicare You Can Opt Into Act is a very simple bill that says any person of any age can buy into Medicare, including the Medicare Advantage plans, and that their premiums would be based on their age. Another plan that we're hearing quite a bit, and it's interesting that we didn't really hear this until this year, is a Medicaid for All plan. And so Nevada had a proposal to have a Medicaid for all, to allow people to purchase Medicaid. That was vetoed or not signed by the governor. Hawaii's been talking about it. Some other states have been talking about a Medicaid for all as well. Jacob Hacker has put out what he calls a Medicare Part E, and Medicare Part E would mean that employers, that there would be a Medicare plan, comprehensive Medicare plan, and that employers would have to offer comparable insurance to that, or if they don't, then their employees would go into this Medicare Part E. And that's a little bit similar to what John Walker is putting forward in his medical insurance and care for all plan, which basically says that if someone does not have insurance through their employer that's as good as this new Medicare plan, then a person would be automatically put into the Medicare plan, and they would be charged a premium most likely through their taxes. And then Paul Starr has been, and some others have been promoting the idea of, in states where the state exchanges don't have a good number of plans to choose from, less than 3 plans, then we should offer Medicare, including the Medicare Advantage plans, on those state exchanges for people to buy into. So these are all kind of variations on a public option type of theme. The other thing that we're hearing is support for lowering the age of Medicare down to 55. Debbie Stabenow introduced a bill 1742 in the Senate, the Medicare at 55 Act. This legislation would basically let anybody who's in the ages between 55 and 64 who is legally residing in the United States to buy into Medicare, including into the Medicare Advantage plans. And then, well, let's talk about some of the weaknesses of this, and then we'll go into the fix the ACA variations. But basically, weaknesses of these various public option plans is that if we add another public insurance to the system, we're basically giving up 84% of the administrative savings that we would have under a single-payer system, because we know that single-payer systems significantly streamline the administration. That when we have opt-in systems, someone can buy into a Medicare plan or a Medicaid plan. At best, 85% of people are going to opt into that system, so we won't achieve universal coverage under that. That the effort of creating a new kind of Medicare plan or a public option plan to buy into would be the same as creating Medicare. We have to create the plan, we have to say what the benefits are, we have to negotiate with the various hospitals, let people know that it exists. But if we're doing it just for a public option that people can choose from, it would benefit far fewer people than if we went through the effort of creating that and put everybody into that plan. And then experience tells us that these public plans would become a sort of a high-risk pool, that people who are healthy and who are working are most likely going to be in their employer-based plan, and then those who have difficulty affording a private plan or have health problems and can't work would gravitate into the public option plan. And then that puts a financial strain on that plan. That when a public option fails, because of that financial strain, the public could, or our opponents could interpret that to mean that public systems, government systems, single-payer systems won't work. So it could actually harm our movement. That just adding a public option plan is not going to solve the other problems with the health system. We're still going to have people who are uninsured, underinsured. We're still going to have the problems that we're facing with our Medicare and Medicaid systems. We're continuing to have the administrative complexity and the financial barriers and all that is causing problems in our current health system. Also, with a public option, the idea is that, if we would regulate private insurance, so it's going to be as good as the public option plan. And we have tried really hard to regulate private insurers in this country. It's expensive to go to the effort of doing that. They're not generally very forthcoming with us. So that effort has really failed. And I think one example we could look at this year is that there was an effort to get the data of the Medicare Advantage plans from the Centers for Medicare and Medicaid Services so that people could start looking at the Medicare Advantage plans in more depth and see how our money is being spent. And that data was prevented from being released to them. So the private insurers are really hold that information close to them, make it difficult for us. Also, with the public option, if we're maintaining this employer-based system, employers really want to get out of the health insurance business. The biggest complaint that we hear through the National Federation of Independent Businesses for small and medium-sized businesses is the cost of being involved with health insurance. They have to hire consultants to help them find plans. They have to help their employees with plans. This is really not something that they want to be doing. It hurts their businesses. And also adding a public option maintains the tiered system that we have in the United States that really continues to be based on someone's ability to pay. So these are reasons why we don't support a public option in any form. Let's look at some of the specific proposals. I said the Medicare BuyIn would allow people of any of, the Shea Porter bill, would allow anybody of any age to buy in. The Sabino bill would just allow people between 55 and 64 years of age to buy into Medicare. Again, it's having to create a new plan, because if you're going to allow people who are younger, you're going to have pediatric coverage, you're going to have maternity benefits as well. As I said, it'll become a high-risk pool. It's not going to get the savings, and it continues to include private insurance. Medicaid for All has many of the similar problems. In Nevada, they were going to continue to have copays and deductibles. It was they had not really figured out how they were going to finance this at all. And then with the Medicare Part E, or the Medical Insurance and Care for All plan, that says that if you're not insured through your employer, then you're put into this Medicare plan. Again, employers don't want to be involved in insurance. We'd have to regulate private insurers. We're still creating a new plan. We're not getting the savings and the complexity. And then if we look at lowering the age of Medicare sequentially, going down to 55 or going from birth and starting up. Again, when you think about the reality of sequentially lowering the age of Medicare, again, you're increasing the complexity for employers. So say you have an employee who's between 55 and 64, and they have a spouse or they have children that are younger than that, then the employer would either not provide benefits to the dependents, or would have to offer another health insurance to those dependents. And especially you start to get down into 45, 35, age groups, most people are often going to be in that situation. If we started lowering the age of Medicare and we have to raise a tax in order to pay for that, then we're taxing younger workers without giving them any benefit from that. And as we know, our youth in this country are already on pretty shaky footing financially. Many of them have college debt. Wages are not very good. So this would be an added burden to them. I think I spoke to this. We'd have to have maternity and pediatric coverage. We're going to be sequentially shrinking the private insurance pool, which is going to put pressure on the private insurers to raise their premiums. We're not going to get that cost savings of single payer. And really, it maintains a lot of the complexity as we're transitioning through that of the current system. So there's also, what we're reading is proposals to fix the Affordable Care Act, and I just wanted to mention these as well. There was an article in The Hill by Ira Rosofsky saying that we just need to make the Affordable Care Act what it should be, and they reference the Swiss type of system, which is the most expensive system, behind the United States, and it's a system of heavily regulated, not-for-profit private insurances. And so what they're advocating for is a much more rigorous enforcement of the individual mandate, and perhaps even making the penalty equal to the cost of a bronze health plan. And that their belief is that if you make the penalty equal to that, then people will just go ahead and buy the bronze plan. And then also requiring insurers to cover minimum essential benefits at a not-for-profit price, but then they can make profits off of supplemental plans. So some of the problems with that type of system here in the United States is that the United States is really not Switzerland. We have a very significant degree of wealth inequality in this country, unemployment, poverty. We don't have as much of a social safety net. So we would continue to have a lot of the same inequalities in this country under a system that includes private insurances. Also that, as I mentioned earlier, private insurers are very good at evading regulation. They're investor-owned entities. They have to make a profit for their investors. So they're very different from insurance companies in Switzerland. Also, we would be continuing to, force people to purchase a shoddy product that leaves them unable to afford their care. And the other proposal that we're seeing, and we heard a lot about this today, I was in the Senate Health, Education, Labor, and Pension Committee hearing, is this Market Stability and Premium Reduction Act. This is a proposal being put forth by the Center for American Progress, and it's being offered as a bipartisan proposal. And it's basically three proposals within it. One is that we would make sure that we guarantee that we're going to continue the subsidies, the cost-sharing subsidies. And the belief is that if we do that, private insurance companies are going to feel comfortable to offer lower premiums. The second is that if insurance companies have very high cost enrollees, that we would reimburse them for the care of those enrollees. And then the third is that, as we know, many private health insurers are dropping out of markets all around the country. And so we would provide a tax break to lure them back into those underserved areas. And really, if you look at it, it's just giving more public dollars to the private insurers to try to get them to continue to pay for health care as they continue to make high profits. All right, let me go to the next slide. So one thing that's really important when we're talking, I think, is that, again, it's based on framing, is that, we hear so much about the public option, and that sounds like a good thing. It's an option, it's a choice, it's public. We need to really call things what they are. And so I've been calling the public option a profiteer's option, because in many ways, it's something that although they scream and yell, the private insurers know that the public option will be a place where the enrollees that they don't want, the ones who are less healthy, will go, and they can continue to profit off of the healthy enrollees. Then also, when talking about how we fix the ACA, instead of saying that we need a public option, I've been saying we need a private extraction. That the problem with the Affordable Care Act is that it's based on a market-based system, and we can't really have universal affordable health care until we get that private out. All right, so we've tried every fix the insurance companies will allow, but we still can't get this system to fly. So how do we move on from here? One thing that I've been talking about a lot this year is what actually is private health insurance? What does it do? How does it actually benefit our system? And, in the United States, commercial health insurance is considered a financial service, not a public service. And it's an entity that, Wall Street investors can profit from. So how do private insurance companies get profits for their investors? They charge the highest premiums they can get away with. They shift as much of the cost of care onto the individual as they can, and then they restrict payment for care as much as they can. And so in this slide, what I did is I went and looked at 4 of the top private commercial insurers in the United States, and this is a trend of their stock value starting from when they began until now. And what we see in these is that, around the time of the Affordable Care Act, after 2010, their stocks started to rise significantly. So in some cases, tripling, quadrupling, quintupling. And so this is what the Affordable Care Act has actually accomplished, is that by mandating that people purchase their products, setting up markets to sell their products, and then giving the insurance companies subsidies so that people can buy their products, we've really strengthened that industry. And so why are we, if you thought about it in the big picture, it just really doesn't make any sense that this is how we base our system. All right, let me go to the next slide. All right, so how do we win this? Really important for us to listen to the wisdom of Dr. Quentin Young and recognize that a lot of people still don't understand what single-payer is, what National Improved Medicare for All is. And Quentin always urged us to focus on the elegant simplicity of a single-payer system. It's really easy for us sometimes to get really wonky when we're talking to people. And so I've broken it down into kind of how I talk about it now when, in general, to kind of a general population. So I use the term National Improved Medicare for All, and then I just break it down based on that. So it's national. every person living in the United States and all health professionals would be in the system. It follows a person wherever they go within the United States, and it's from prenatal care through their death. That it's improved, that the care is more comprehensive than our current Medicare. It includes all medically necessary care, including long-term care, without copays or deductibles, and that it's Medicare for all, like Medicare. It's financed up front. We recommend a progressive tax so that each person is paying according to their means and not according to their health status. So I think it's still important for us to remember that people don't all know what it is when we say single payer or national improved Medicare for all. Oops, let me go to the next slide. All right, so I wanted to backtrack a little bit and talk about kind of the history of health reform in the United States and why it's so important for us to not repeat the mistakes of the past 100 years. And Professor David Barton-Smith is a professor emeritus from Temple who now teaches at Drexel and has written about and studied health reform in the United States, and has an excellent chapter, which I'll try to share with you, that goes through the period from 1916 to 2016. And he writes that throughout that time, the fundamental conflict has been whether we treat healthcare as a public service or a commodity. It can't be both. We have to choose whether it's going to be a public service or a profit center. And that when healthcare is viewed as a public good, there's a sense of social solidarity, that we're all, in the system together. It's something that benefits all of us. But when it's treated as a commodity, people don't want to pay for more than they need, or they feel like they're ripped off. So it creates this real kind of contradictory incentive when we treat it as a commodity, and really strips away that sense of social solidarity. He says that the basic requirements for achieving our goals of a universal system is compulsory coverage and effective government oversight, and that there are 5 phases over the last 100 years of trying incremental, or what he called more palatable, approaches, and every single one of these has self-destructed. And so if we don't want to keep repeating these mistakes of the past of trying these lesser approaches, then we really have to buckle down and say it's time for a universal social insurance. And he writes that every other country has learned that lesson as well. So he goes through the 5 phases, and I don't want to go into them in detail, but they are in the chapter. But it's kind of like a group solidarity, which was various groups based on identity who felt like they could come together and help each other out, and that they didn't need the government to get involved because they could take care of each other. Then there was a volunteerism phase of, voluntary purchase of a nonprofit insurance through the Blues. And then in 1965, with the advent of Medicare and Medicaid, bringing in public systems to kind of patch up the holes, but continuing to allow the private to operate. We saw rising healthcare costs at that time, and so they brought in the idea of managed care. And then when that didn't, work out, we've seen increased privatization of our healthcare system. So those are kind of the 5 more palatable or incremental approaches that we've taken over time. So he says no more compromising, that the practical mechanics of how to make a universal health insurance system work are a lot easier than patching together the existing hopelessly fragmented private-public health insurance system. The Medicare program actually does this quite well, and the cry of Medicare for all has never been silenced. Indeed, no one has ever objected to their mandated coverage under Medicare. So now, really is the time. We have to take on this fight. And the United States, as we all know, is already spending twice as much on health care per person per year as the average industrialized nation that has universal health care. We're leaving tens of millions out, tens of millions more who are underinsured, wasting hundreds of billions of dollars each year. And that why should we keep paying more and sacrificing people's lives to ensure that profits for health insurance and other medical industries? For those who believe that we should take a lesser approach, we would ask, who should be sacrificed to keep healthcare profitable? And let's go into a little bit of how kind of social transformation occurs. So much, it's interesting, so much of these articles are of these incremental approaches. They're trying to say that we can kind of sneak our way into a single payer system, that we can do these public plans and they're going to weaken the private insurance industry enough for us to finally have single payer. But I believe there's no backdoor to National Improved Medicare for All, that no matter what we do, we're going to face opposition. And so let's have confidence that we're on the right side of history, that for 100 years, people in the United States have wanted a national health insurance, that we represent the majority, and we can take that opposition on. That we need to remind ourselves that throughout history, every social movement has been told that they were asking for too much. So this is not any different. And that how we win these fights is that we change the political culture so that what people once believed was impossible becomes inevitable. Just the culture is so that that is the only solution that people support. It's the only one that's feasible. And how do we do that? By building movements, by running a campaign for that. It requires education, as all of us know, being involved in PNHP, also outreach to build relationships with other groups, because healthcare justice really unites us across boundaries. And then mobilizing ourselves to take action and escalating our pressure over time. So in each of our campaigns, we have to recognize that we're going to have to keep kind of building that pressure over time to change that political culture. And an acronym that I've been using is ICU. I often say that we have a healthcare crisis and we need the ICU, just to help people remember it, that we need to be independent, clear, and uncompromising in our demands for National Improved Medicare for All. And independent to me means that our allegiance is to the issue, and we have to recognize that neither major political party in power right now really supports single-payer health care. And so we don't want to tie our agenda to the agenda of a particular political party or a particular politician. We have to stay independent and be willing to push on them when it's necessary. That we have to be clear about what works and what doesn't work. We know that there are going to be lots of different distractions floated out there to try to take us off track from our goal, and that we have to be uncompromising. We're so often told that politics is about compromise, but I think of a quote that's been attributed to Ghandi where he says you can't compromise on fundamentals because it is all give and no take. This is one of those fundamentals. If we want to have a healthcare system that's universal, that improves health, we have to make health the bottom line of that system through a National Improved Medicare for All. That's the first step, and then there's a lot of work to do after that. And so when people tell us that we have to compromise on this, what they're really trying to do is take our power away, and we can't allow that to happen. There's so much also in the news right now about making single payer a litmus test for politicians to get reelected. And, is it a litmus test? Is it not a litmus test? And there's a quote from Dr. Quentin Young's autobiography. And he was talking about right after the Affordable Care Act was passed and whether if he was in Congress, would he have voted for it or not? And he says, I don't have any sympathy for the idea that the president had to compromise because his opposition was strong. I'm sorry, someone else is talking. Please mute your phone if you can. I don't have any sympathy for the idea that the president had to compromise because his opposition was strong. Winning is not always winning the election. Winning is making a huge fight, taking the fight to the people, re-electing people who are supporting your program, and defeating those who aren't. So this is how social change has occurred, by doing absolutely the task of making it a litmus test for those who want to get re-elected. And just finally, imagine what it will mean for our country when we achieve National Improved Medicare for All. We will actually have a policy that says that people are more important than corporate profits, and that all people deserve the same high-quality health care. It will create a sense of social solidarity because we are all in that same healthcare system, and so we'll be fighting to make it the best system that it can be. And it will empower us to win other critical struggles that we face right now. And I just want to close with a quote, another quote that was attributed to Ghandi first they ignore you, then they laugh at you, then they fight you, and then you win. So we are in the fight you phase, and we never know how close we are to victory. And so when people say we're not going to get this until this time, or we're not going to get this till this time, the reality is when we build a strong, clear, confident, courageous, popular movement that demands national improved Medicare for all, we will win, and we never know how close it is. A friend of mine was in Germany meeting and talking to activists before the Berlin Wall came down, and he said to them, how long do you think it's going to be before people, before the wall comes down? And they say, well, we hope that maybe within a year we'll be able to travel back and forth, and within a week the wall came down. So we really never know how close we are, and the fight always gets the hardest right before we win. So I put in here an image from the Yes Men, if you're familiar with them. They had a fake New York Times, and the headline of one of the stories was National Health Insurance Act. Oops, I'm sorry. National Health Insurance Act is passed. So that day is coming, and it's up to us to stay on course and to continue to fight for it. So I'll stop there. And Matt, I'm not sure how you want to do questions, but I'm happy to take questions or comments at this point. Okay, so it looks like there's a question from Thomas Claremont Masters. Richard Masters' Fix-It movie laments the albatross of employer-based health insurance. Why does this view and his conclusion that we need Medicare for all resonate with businessmen, and why aren't they demanding it now? So what's interesting is that we are starting to see a shift in the business community. I think part of it is not being aware of this as an option, and not having a significant organizing in that area. So Masters created a new organization this year called Business Leaders Transforming Healthcare, and I think the website is blth.org, and he's working with the American Sustainable Business Council to reach out to business people and start to build that contingent of support for National Improved Medicare for All. And we're talking about hopefully, down the road, pairing health professionals and health advocates with business people and coming in and meeting with our members of Congress together. So I think that's growing, and it's interesting that Warren Buffett and his partner Charlie Munger, who, Charlie Munger is pretty conservative, are both saying that we need a single payer system, that it's hurting not only the smaller businesses, but it's impeding the competitiveness of larger businesses in the international world as well. Someone's asking if this is going to be available online later. Yes, I will make the slides available, and I know that Matt is recording this presentation as well. Let's see. Another question from Walter: what happens to the billion of shareholder dollars invested in the for-profit system? So I'm guessing that you're asking, when we go to a single-payer system, what would happen to those investor dollars? It really depends on what that single-payer system, ultimately turns out to be. I know under HR 676, Congressman Conyers has put in there a 15-year transition period where the government would basically buy out investor-owned entities of the system to compensate them. So yeah, it kind of depends on what the details of that system are. Are there any other questions or comments? You can put them in the chat box, or I'm happy if you unmute and ask. Andy asked, why is the Medicare system so susceptible to fraud? How can we answer that to people who are detractors of the system? So one thing that's interesting is that, two things. One of the reasons that the Medicare system is susceptible to fraud is that it's a guaranteed payment. And so people, sell things that aren't necessary, or try to bill Medicare for things that aren't valid, because they know that they'll get paid for them. But we find that fraud because it's actually a public system, and we have the ability to look at the system as a whole and see, where the money is going, and to check and make sure that it's being used appropriately. And that's something that we don't have in the private system. We don't have that transparency to be able to know if there's any fraud being committed. I mean, there have been cases over the years of finding out that insurance companies were committing fraud, and they usually just get charged a penalty and they continue to behave the way that they behave. So fraud always exists. When we have a publicly transparent and accountable system, we can identify that fraud and deal with it. Jeremiah says, hopefully a lot of the saved money will decrease the national deficit or open the door for other social programs. So we certainly know that under the current system that it's eating more and more into our gross domestic product every year, and that system is really not sustainable, as well as if we think about it in the big picture, what it's doing to families. We have the majority of families in the United States have very little liquid assets. They can't handle an emergency more than $500. And so cost of healthcare put a huge burden on families and prevent them from being able to spend their money on other things that they need. We know that people who are very wealthy tend to hoard their money. People who are of lower incomes, which is majority really now, tend to spend their money. They have to pay for their clothing, their food, their, where they live. So allowing that kind of shift in money and allowing people at the bottom to have more money would actually be a stimulus to the economy. So there are really a lot of benefits to doing a national improved Medicare for all beyond kind of what the obvious is. And so that in itself would help to hopefully reduce the national deficit. As far as opening the door for other social programs, I think just the empowerment that would come from winning something of this magnitude would really empower the people to fight for the other needs that we have. There's a new index that has been put out by a few groups like Oxfam looking at inequality of nations, and it's an index looking at whether nations are taking steps to reduce the wealth inequality that they have, and then ranking them. And the United States, with the highest wealth inequality of the industrialized nations, they have 3 basic recommendations and for how to reduce that wealth inequality. And the number 1 recommendation is to put significant public investment into healthcare, education, and other social programs. And so I think we should be using this to kind of say to our legislators, look, here's what we should be doing. They also say that we should tax wealth so that we can pay for these programs. And we know that our GDP is growing. It's not that we don't have wealth in this country. It's where it's going. And then the 3rd recommendation that they have is more power to workers to be able to have better wages and benefits. Is there another question? Henry, why are you so strongly opposed to state efforts to achieve a single-payer system? New York and California bills eliminate the role of private insurance and offer comprehensive care. Studies have shown affordability. I used to be a supporter of state single-payer. I helped to write the state single-payer bill here in Maryland and advocate for that. And I think what we've learned over the last number of years is that it's really not possible to do a pure single-payer bill at the state level, that you have to go to the federal government in order to make that happen. And so if we're going to have to build a movement to fight for the federal government to allow a state to do it, I believe that we should be using that energy to fight for a national improved Medicare for all, especially since that's where the momentum seems to be right now, so that every person living in the United States can have access to health care, not just someone who lives in a state that's willing to do it. I know people often point to Canada and how Canada did it, starting with one province, but they didn't really face the federal barriers that we face in the United States right now. They had much more of a blank slate to work from. Michelle says the common argument I've heard is that low administrative costs of Medicare is due to pay and chase system with high fraud. So I'm not sure what a pay and chase system with high fraud is. Maybe Michelle, maybe you and I can talk about that offline. more. I think the low administrative cost in Medicare is just that it's a very, it's pretty efficient and simple system that has one basic set of rules instead of the very complex system that we have right now. Rick says, states' initiatives may be the most politically feasible. No, how are they doing? We've had a number of state initiatives over the years, Vermont, Colorado, California, and, they have not been successful yet. That doesn't mean that they couldn't be successful in the future, but they can't actually it's very difficult to achieve a pure single payer system at the state level. Jeremiah asks, without knowing the specifics yet, do you fear Sanders' new bill will be plagued by incrementals like copays, and do you think it will overshadow 676 and make it complicated? So we have been pushing Senator Sanders throughout the year to introduce a companion bill to H.R. 676, and as many of you know, he's writing a bill. It is still being drafted and is anticipated to be released next week. It's much more similar to H.R. 676 than his past legislation has been, and I think we really have to look at what the final language says. But it sounds like he is responding to people who have been reaching out to him and advocating for there to be no copays and to, make it a strong single-payer bill. But no matter what it is, what it comes out to be when it's finally released, I think it's important for us to think of the ICU acronym and to be really clear about what it is that we want in our single-payer system, and to continue to push on the Senate bill and encourage them to, if it's not what we want, to encourage them to, strengthen it. Let's see. George asks, how will a single-payer system address the health needs of undocumented persons? First off, the single-payer systems that we advocate for would include every person living in the United States, whether they have papers or not. Second, how does the current immigration debate in the country interface with the debate on the need for healthcare system change? And I think that, in addition to a complex healthcare system, we have a really complex immigration system that has a lot of barriers in it as well, and a lot of it doesn't make sense. And when you think about healthcare and look at the numbers, we know that the population of immigrants in the United States is actually subsidizing our current Medicare system, and they're not getting the benefit from it. So I think it's important for us to be upfront about these facts, and so I think that it's also important for us to see the connections between these various fights, and that if we want a healthcare system that is a strong system from a public health standpoint that's going to protect all of us, it's important that everybody in the country be able to have access to healthcare when they need it. Particularly, the most obvious is infectious diseases, that by making sure that people have access to care, we have a better ability to treat and control infectious diseases before they become epidemics. But also the reality is, if somebody has a significant health problem and has an emergency, we're not going to ask them, hopefully, whether they have papers or not. We're going to treat them. That would just be cruel and inhumane. Kay says, we see new attacks on H.R. 676 from some of the congresspersons who've signed on. Now they say it can't be implemented as written. How can we effectively respond? I think it's important for us to say that H.R. 676 is a framework that outlines the highest quality system that we could have in the United States. And we're already, again, paying the most. So we should have a very high quality system here. And that we know we have to work out more of the details, and that we would like those congresspersons to get involved in that process and join that dialogue to help fill in those details and make it be a very strong bill. We also know that there's a lot of good information about details and how to transition out there in the various articles that have been written, and that the reality is that H.R. 676 is what we need to solve our healthcare crisis. And so we hope that they'll get involved in helping to make that happen. Let's see, Wayne says, one overlooked area is our local government. Many of these are fighting to keep their budgets intact so as not to increase local taxes. The main issue driving the budget increase is the cost of health insurance. We need to reach out to these folks in building our momentum. Yeah, and there have been tools used in the past. I think one was called the Win-Win campaign, to reach out to local governments and just show them how much they would save on the insurance for their public employees under a single-payer system, and help them to imagine what they could do in their city or town with that money. Maris asks, could you propose some concrete actions that individual healthcare professionals and future healthcare professionals can take to contribute to the social and political change required for national improved Medicare for all? That's a great question. I think that, each of us has, the resources that we have in terms of time, energy, and money. And so it's important for each person to kind of look at what they're able to contribute and recognize that as long as we're each contributing in, we're contributing to this, to this goal. And so if it's, talking with your colleagues or talking with your patients or people in your community or your family members about this, and telling them that you support this, and answering their questions, that's something that each of us can do in our daily life. I was at the post office the other day and had a lot of packages to mail out, and so got into a conversation with the postal clerk who had never heard of National Improved Medicare for All. So we really can do this in our daily life. If you have more time, you can get involved more with Physicians for National Health Program or Students for National Health Program, and learn how to talk about this so that you can give talks in your community or give grand rounds. That's something that I do pretty regularly. You can, provide monetary resources to organizations like Physicians for National Health Program so that they can do more. And if you're able to actually be active in your local chapter of PNHP, then you can help with outreach and kind of building your local movement. Meeting with your legislators is another thing. We do a lot of that, just educating health staffers and members of Congress about this. And then, over time, as we kind of need to escalate this campaign, I guess right now what we're trying to do is encourage our legislators who have signed on to HR 676 to be more active supporters, to post about it on their websites, to write op-eds about it, or speak in the media about their support, or hold town halls on it. So we really need them to be active supporters. And then trying to encourage members of Congress who have not signed on yet to do that. Those are more things that we can do. But if we actually start to get some traction in Congress and we're starting to move these bills through, then we're going to need to really be, in contact with them regularly, perhaps even escalating our actions and our pressure. I think about a campaign that we had over the last 6 years to stop the Trans-Pacific Partnership. And this was a huge trade agreement. And we really had to do things like sitting in their congressional offices in order to put pressure on them to not support the Trans-Pacific Partnership. Craig says the private health insurance industry employs many people. Would these people be able to be retrained to work in single-payer system? So that's a great question. HR 676, and it's an easy bill to read. I recommend that you do that if you haven't. You can go to thomas.loc.gov. LOC stands for Library of Congress, and look up HR 676. And it includes a 2-year period where first off, anybody who's displaced from their job because of the new system has priority to be hired into the new system. If they're not, then they can receive up to 2 years of like a severance pay. I'm blanking on the term right now, and also job retraining. And there are a lot of health professionals who have left direct patient care to go into administrative positions. And hopefully some of these people would be interested in coming back into direct patient care. We definitely have a lot of jobs that we would need in the new system. Let's see, is that it? Let's see. employers may emphasize that employees will forfeit excellent care for a lesser public care system. And really the idea of the single payer system is that it be very comprehensive, better than what people have now without the cost sharing. So it looks like we're at the end of the hour. If you want to be in touch with me, I'm happy to, take emails from you and continue the conversation. My email address is md, as in Maryland, md, pnhp@gmail.com. So it's Maryland, md, pnhp@gmail.com. So please reach out to me, and I appreciate you taking time to be on the call tonight.